Good morning, everyone. I'm Dr. Mansi Dinesh, a second-year postgraduate from All India Institute of Medical Sciences, Mangalgiri. And today I'll be presenting conservative and interventional approaches in the management of indirect carotid cavernous fistula, or CCF. So these, as we know, are abnormal communications between the carotid system and the cavernous sinus. They can be classified in many ways as direct or indirect, traumatic or spontaneous, high or low flow fistulas. And they are classified anatomically by the Barrow classification. So these can present with a multiple myriad of ophthalmic features, as I will highlight in the following case series. The first case was a 74-year-old woman who presented with protrusion of the left eye along with redness, watering and pain for the past 1 month. There was no other significant history. And this was the clinical picture on the left eye. So on examination, the right eye was within normal limits and the left eye showed some degree of ophthalmoplegia, proptosis, dilated tortuous conjunctival corkscrew vessels, and in the fundus there was a small hemorrhage near the optic disc. The intraocular pressure was also elevated and the exophthalmometry showed 25 millimeters, confirming the proptosis. So we diagnosed this case as a case of left eye axial proptosis with external ophthalmoplegia, and we had sent the patient for imaging on suspicion of CCF. So on CT angiography, MRI, and then finally a confirmatory digital subtraction angiography, it was revealed that there is a bilateral indirect CCF. Here we can see the cavernous sinus being opacified, the inferior petrosal sinus, and the superior ophthalmic vein, which should not be ideally filled in the arterial phase of the contrast. So this patient was managed by a transvenous squid embolization. So here we can see again both the cavernous sinuses are opacified and multiple feeder vessels are seen going from the carotid system to the cavernous sinus. So to treat this patient, first a diagnostic catheter is parked in the external carotid artery for angiography purposes. Then the femoral vein is cannulated and we gain access to the cavernous sinus and inject a liquid embolic agent like squid into both the cavernous sinuses, and after that we check if the sinuses are completely occluded, and after doing this procedure we repeat the angiography, and here we can see that the cavernous sinuses are completely not getting filled in this phase and the feeder vessels have also significantly reduced. So this was the pre-op picture, and after 2 months post-operatively she has come back to normal. The corkscrew vessels have reduced and the disc hemorrhage in the fundus also resolved. The second case was a 60-year-old woman who presented with both eye redness and protrusion for the past 1.5 months. As we can see here, there was bilateral proptosis, lid edema, chemosis, and this patient also had multiple corkscrew vessels in both eyes, and the exophthalmometry was 23 and 21. So again, she was a case of both eye axial proptosis with ophthalmoplegia, and on angiography, we can see that the cavernous sinus is opacified and the similar picture is seen where multiple feeder vessels are there, and this patient was also managed with squid embolization of the bilateral CCF. And after the embolization we can see that there is no filling of contrast here and the number of tiny feeder vessels has reduced, and gradually over a few weeks even the residual feeders will also reduce. So after 6 weeks of embolization, she has almost come back to the normal state. The third case was a 57-year-old woman who presented with both eye redness for the past 2 months and diplopia. She had a history of trauma 3 years ago. She is a diabetic and hypertensive but well controlled. So she also had some degree of ophthalmoplegia, both eyes had corkscrew vessels, and there was also incidentally a shallow anterior chamber. So this patient was subjected to angiography as well as a YAG laser iridotomy. So here the angiography revealed a type 4 indirect CCF, and this patient, since the veins were too thin to access by the radiologist, they had advised for conservative management. So she was advised at home to do carotid massage to herself using the contralateral hand and occluding the pulse of the carotid for around 10 seconds. And this is to be done 6 to 15 times a day. And after 1 month she was followed up and she responded very well to the conservative management, and the corkscrew vessels and all have reduced. So coming to the discussion, the main culprits in CCF are superior ophthalmic vein, which cause the ophthalmic symptoms, and the sphenoparietal sinus, which may rarely cause intracranial hemorrhage. So in these patients we need to do a CT screening, MRI, and a gold standard which is DSA to diagnose and characterize the fistula. And there are many management options, like we can wait for spontaneous closure, there are compression, carotid massage, direct surgery, radiosurgery, but now the first line of intervention is endovascular intervention with a high cure rate. So the indirect CCFs are managed as I have described by the transvenous route, but the direct CCFs will be accessed transarterially and the rent will be directly repaired. So to conclude, CCF is a rare case, but it must be considered as a differential in a case of proptosis, congestion, and corkscrew vessels, especially when presenting with ophthalmoplegia. And it's not that as an ophthalmologist we refer and forget the patient. We have to follow them up with the help of the interventional radiologist and keep a tab on the complications developing, and we have to take care of them along with the radiologist. Thank you so much.
very nice presentation. I have a few questions actually. So, did what were the outcomes that you were actually looking for? The proptosis to be coming down, or the visual acuity actually coming back? Was the visual acuity anyways affected to begin with?
Not significantly, sir. In all three cases, the visual acuity was not affected. The main problem they had was ophthalmoplegia because of cranial nerve paresis. So that was looked for, and the proptosis had to come down, and the corkscrew vessels had to resolve. So these were the main outcomes that we were looking for. And luckily, these patients did not have any optic neuropathy at presentation. Maybe they were picked up early, so that was not a problem. But even that should be documented. Any RAPD is developing or on follow-up that has resolved.
So did you notice any one of them? Any component of optic neuropathy was noted? Any of these patients of the?
In all three cases, luckily there was no optic neuropathy, sir. There was only paresis of the cranial nerves causing ophthalmoplegia, but those also resolved after a few weeks post procedure, sir.
Optic nerve. Otherwise, the findings of optic nerve, as in the components of vision, as in fields, color contrast, was documented in all these patients or not? Because usually proptosis patients you are supposed to document in all patients.
Yes, sir.
So yeah, that is one thing. And there is a sign which has been described for like we have ourselves described the boomerang sign. Have you heard of it? It's basically the superior venous, superior ophthalmic vein. It becomes dilated, especially in case of CCFs.
Yes, sir.
So I'm expecting that to go away. The sign will disappear post the intervention, and once the management is complete, then that will be one of the indications that the treatment is also completed or possibly successful. If it still persists, that means there is also continuous episcleral venous pressure which is still persisting.
Yes.
Anyways, very nice presentation.
Thank you, sir.
Yeah.